Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Adriana Rossi, who's director of the CAR-T and Stem Cell Transplant Clinical Program at one of the leading myeloma programs in the country. And she is going to talk to us about ISATUXIMAB for frontline transplant ineligible patients. We'll focus more so on two trials that were presented at the recent ASCO 2023 meeting. Welcome, Adriana.
Thank you. It's so nice to be with you and to review some of this new data.
So let's get started. So obviously, one of the presentations that has been talked about a lot is this IMROZ study. So can you tell us about what the study was about? And we'll come to the trial design in a minute.
Absolutely. So it's really exciting. It's the first, phase 3 study using ISATUXIMAB, which is second CD38 monoclonal antibody in myeloma, this time specifically looking at newly diagnosed and transplant ineligible. So we do have a lot of data in the relapse setting, but now we're looking at the newly diagnosed patients, comparing the addition of ISATUXIMAB to what is arguably our standard backbone of VRD.
So can you tell us a little bit about the trial design?
Yeah. So this, interestingly, they did accrue about 446 patients, and the randomization was 3-2. So it wasn't an exactly balanced. There was a slight additional slots for the study arm. And it's an interesting schedule. It's definitely not what I would consider my standard schedule in the United States. But it's important to realize that there is first an induction phase, which for either arm was 4 cycles of 6 weeks each, followed by a de-escalation to what is called continuous treatment, which is the second part. So ISATUXIMAB is dosed in the regular weekly schedule for the first 6-week cycle. And then it's added the bortezomib. Again, the original data is day 1, 4, 8, and 11, and that's how it's used here. However, I think most of us in practice are using it weekly. And in order to comply with that, 6-week or 3-week regimen, the lenalidomide is days 1 through 14. So 2 weeks on, 1 week off. And the dexamethasone is days 1, 2, 4, 5, 8, 9, and 11 and 12. So a lot more dex than I use in our usual practice, but certainly sort of the most studied combinations. And then the control arm is the VRD, so not using the ISATUXIMAB. And interestingly, you then switch from the induction to the continuous phase where there is no bortezomib. I think that's one of the most important parts, is even though there is such dose intensity, it is only during those first 4 cycles, and then neither arm continues the bortezomib long-term.
So anything to point out regarding the demographics of the patients accrued on this study?
I think one of the really glaring things is the age. So the title of the study is Transplant Ineligible, and while age is not a fixed determinant, it definitely seems to play into it. And there are different requirements for Europe and the US. So I do notice that even though the median age is 72, patients are as young as 60 or 55 were included. But I think it's not irrelevant, right? It's a slightly different data set, maybe. I'm also of the opinion that labeling our patients transplant eligible or ineligible is becoming an increasingly dated way of thinking about our patients. These are patients who were not transplant intended. And while 10 years ago, I would definitely try to transplant anyone that I could, with the changing landscape, with the alternatives that we have coming down the line, and with our options for salvage therapies, I think this is just an older patient, transplant not intended, fits better as a definition.
So what was the primary endpoint readout like?
So amazingly, we now have 5-year follow-up data, and the PFS at that 5-year mark was 63% for the study arm compared to 45% in the control arm. And it's very significant and increasingly separating curves. So it will be interesting to see as the data matures where those numbers finally fall out. But it does highlight that at 5 years, we still don't have a median PFS.
And what can you tell us about the depth of responses achieved in the two arms?
So it's a really nicely done study. It did have MRD follow-ups. So at month 12, 18, 24, and yearly thereafter, they're looking not only at being able to achieve a depth of response, but also to be able to sustain that MRD negativity, which is really, I think, our gold standard in 2024. And while both arms had a really great overall response rate, I think the depth of response was markedly better. If you're comparing the CR rates from basically 75% down to 64%, so a marked improvement in the depth. And similarly, when we're looking at the ability to achieve an MRD negative CR and then to sustain it for 12 months, we have almost twice as many patients at that 12-month mark sustaining that depth of response.
What about survival?
Well, absolutely too soon, right? If we don't have a median PFS, I think OS will definitely be another 5 years down the line. But we can appreciate that after about 4 years, the curves did start to separate, and there's an early trend in that direction, but too soon to tell.
And what can you talk to us about the causes of death in this trial?
I think this is a really important figure that reminds us about this patient population, right? Our older patients are doing so well that death is usually not due to myeloma progression. And so we have a lot of competing mortality in this patient population. And interestingly, the death not due to progression were almost identical curves regardless of treatment arm. So that really just highlights our background population. When we look at specifically death due to myeloma progression, the control arm is almost twice as frequent as the study arm. So really, really impressive data that the use of the quad, even for a finite period of time, is giving us marked survival outcomes in the long term.
And how is this tolerated?
Really, really well tolerated. It's interesting to note, again, remembering that the randomization was 3-2 and looking at the median treatment duration, patients on the ISA-VRD arm stayed on treatment for about 53 months as compared to only 31 months in the control arm. And so while the overall number of AEs seemed bigger in the quad, most of them, when evened out here in the second part of the table for patient years, really just reflects that patients are on therapy a lot longer. And so both the incidence and the serious AEs, fairly well balanced among the two. So no new safety concerns.
What specific AEs were observed or need highlighting with this?
Yeah, as with everything else, I think the most common were the hematologic toxicities, and we're all quite comfortable with those. And not surprisingly, but worth noting is that as we see with other anti-CD38 antibodies or targeted therapies, pneumonia does seem to be slightly more of a risk. And so attention and prophylaxis for the patients where it's indicated, I think, is important. And it's nice to have a little data on the SPMs. Again, remembering that we're looking at an older patient population. While the numbers are still small, they were mostly solid tumors, which I think are just the expected SEER data for this patient population.
So there was another presentation at the ASCO meeting with ISATUXIMAB in a similar population. Can you put this in context?
Yeah, I think this one is really a beautiful study. It's an academic study, so it's not, I guess, what we would have expected. This time comparing that same study arm of isatuximab with lenalidomide, dexamethasone, and bortezomib, but to a control arm that is ISATUXIMAB plus lenalidomide and dex. Similar population, newly diagnosed transplant ineligible patients.
So what are the salient points that this study brings out?
So this was a really nice study. I think not only it's the comparison, but it really gives us data for both the quad ISA-VRD and the triplet ISA-RD for our patients with transplant ineligible. Many of us may lean towards triplets in these patients, and ISA-RD really hasn't, we haven't seen data on it. So it gives us data for both regimens in this population.
So obviously VRD or VRD light used to be a popular regimen that got displaced by CD38 with RD, daratumumab RD being an FDA approved regimen. So this is using an analogous, I guess, control arm, which some people may feel is more contemporary, a CD38 with RD as the control.
I think that's exactly it.
And I think that the schedule of administration was somewhat different in this trial.
Very much. This is to me much more in line with my daily practice in the United States. The randomization was 1-to-1 at this on this study. And again, we had this treatment phase, which was separated into the first 12 cycles, then the cycle 13 to 18, and eventually for those patients who are still on cycle 19 and onwards, really speaking to how well tolerated it is. And while we start with the weekly isatuximab, the bortezomib is again used weekly, which is much more in line with our practice. The lenalidomide is 3 weeks on, 1 week off. And with time, we de-escalate to every other week and eventually just the once monthly. And again, the bortezomib is of limited duration. Once you get to what may be considered maintenance, to use our old language, no bortezomib. So it's really using the quad for a finite amount of time and then de-escalating as we are able.
And so what was the trial population in this trial like?
It was a little bit more in line. Similarly, the average, being 73, but here the youngest patients were 71 on both arms. So very well balanced and very well spread on the below 70, 70 to 75, and over 75, all being very well represented. And in the IMROZ, we did have a limit at patients for 80 years old. Here, patients could be older than that. So I think it does capture our American transplant ineligible population very well.
And what was the primary endpoint readout like?
Another very impressive first, it's a MRD negative as the primary endpoint. And I think that's very reassuring, given as we saw at 5 years, we still don't have PFS. So this is an early glimpse to really be able to see a marked difference. So looking at MRD negativity at 2 different time points, at 12 months and again at 18 months, again, speaking to that sustainability, but also at 2 different depths, 10 to the -5, which I would say is our standard, and 10 to the -6, which is our, best available. And I think part of the importance to highlight, while the primary endpoint is that 10 to the -5 at 18 months, all 4 of these graphs look very similar, with about twice as much MRD negativity in the ISA-VRD arm than the ISA-RD arm, and all of them deepening from 12 months to 18 months.
And so this kind of shows what you just said, that the responses deepen over time.
Yeah, which is again very reassuring.
So what about the kinetics of response over time in other aspects and the response rates?
Yeah, not surprisingly, the quad had a slightly higher overall response rate, but both of them, I think very impressive. And as you mentioned, the kinetics are I think support both, both of these regimens are getting you to a very high level of sustained response. The quad just gets you there faster. So I think it's very reassuring to see that a little more intensity up front can get you to the depth of response faster. But both regimens really are, I think, very beneficial for our patients.
And what can you tell us about the PFS and the OS at this time?
Yeah, way too soon to say. We're approaching 2 years of follow-up and they look absolutely identical.
And the safety?
Similar, again, I think given the limited dexamethasone on this regimen, we really see a lot less toxicities and both very well balanced. I find it interesting that the AEs leading to discontinuation are incredibly well balanced across all the different drugs. And ISATUXIMAB is really the least common, so highlighting how well tolerated this drug is.
Any specific organ toxicities that you would like to point out?
Just the use of bortezomib really, I think we associate with peripheral neuropathy, and I thought it was interesting to see that the control arm did have a significant proportion of peripheral neuropathy. So it's important for us to remember that our diabetics and all the other comorbidities in patients, especially as they're a little bit older, it's not all drug related.
So, having reviewed these two abstracts that are potentially practice changing in the future, we'll get to the future in a minute. But how do you treat your transplant ineligible patients today?
I would say, we do tailor each to each individual, and what transplant ineligible means is a moving target. But the simplest answer I would say the practice would be the quad of a CD38 proteasome inhibitor, IMiD, and dexamethasone when they are considered transplant eligible. And I would try to avoid the proteasome inhibitor in a transplant ineligible patient. So that may have been until this week. As this new data matures and we get approvals, I think more and more as that line moves on patients who can tolerate, because starting a quad, we're not committing to long-term quad. And we now have the data to support exactly that thinking of giving them that benefit of a quick, deep response, and then de-escalating both to improve tolerability and to sustain it over a really long time point. So I think more and more of them are going to be eligible for quads.
So, as far as your practice today goes, you say it's CD38 antibody with lenalidomide and dexamethasone, and you continue the lenalidomide and the daratumumab till progression. How do you do that? When do you drop the dexamethasone? Could you just give us a little clue about your practice?
Absolutely. So again, I do try to start all of the drugs, at a therapeutic dose, and I will follow the response and tolerability. So cycle by cycle or more frequently, if anything comes up, should there be an intolerance, be it GI intolerance or cytopenias, I am quick to reduce the dose. Again, sort of borrowing from VRD light, it's better to keep patients on a lower dose that is better tolerated in the long term. The DARA, I've not changed dose or schedule. And I continue the triplet. I usually lower the dexamethasone after the first cycle, depending again on whether they're diabetic, if they have another intolerance. And then I would continue the triplet to best response. Once there's a plateau or a complete response, then it's a discussion on what the patient prefers. And I would say about 3/4 of patients would prefer the lenalidomide as a continuous maintenance. But I do have a number of patients who opt for a subcutaneous injection once a month rather than any of the toxicities they feel with the lenalidomide.
So, what dose of lenalidomide do you start with initially before you de-escalate?
Usually 15 milligrams for this patient population.
And you mentioned either lenalidomide or the CD38 antibody long-term. Do you continue both in some patients?
Patients who have high-risk features definitely will benefit from both as long as they're able to tolerate it. And generally, I've found this combination to be very well tolerated.
As regards the dexamethasone, you mentioned going down on it as early as the second cycle. I know that some people in the past have felt that the steroid is absolutely necessary for the preventing reactions to daratumumab. I understand that that is something that we can actually omit after a while now without putting patients at risk for daratumumab or isatuximab-based reactions. Is that correct?
Yes, as far as the daratumumab, I think many of us were really struck by the intravenous formulation. It's been my practice for years now to exclusively use the subcutaneous, and there's so much lower infusion reaction rates with the subcutaneous than with the IV. So I think one thing to keep in mind is the method of administration, but I would do 20 milligrams for the first 4 weekly injections, excuse me. And then I'll usually cut down to 12 milligrams by the second cycle. And if someone is, again, diabetic or having a really hard time with any tolerability, they're very vocal here in New York City. So I will go down to 8 milligrams for usually while I'm trying to deepen the response. Once the plateau is reached, I'll discontinue it altogether. Or in a patient who is having glycemic issues or not sleeping or whatever the complaint, I can do without it after the weekly, once I go to the every other week schedule.
And you mentioned going forth when this becomes an FDA-approved regimen that there will be utility for quads even in non-transplant eligible population. But you also seem to suggest that not every patient who is transplant ineligible may be getting a quad in your practice. Can you just briefly expand a little bit on who you think you will offer the quad to and who you would continue the triplet for?
Yeah, it's part of what I love about treating myeloma is that there isn't really an algorithm or one way to treat, and each individual that comes in, we can take into account disease characteristics. So certainly someone with standard risk, low burden of disease, maybe an incidental lab abnormality will be very different than a patient with a high burden of disease or maybe renal involvement or high-risk cytogenetics. So we can take all of those myeloma-related factors and then patient-related factors, how easy it is for them to access our clinic. Are they coming from far away? Do they have mobility issues due to the disease? I have a good proportion of our patients are still using walkers. And usually, especially in the newly diagnosed, their performance status may actually improve with therapy. So having the flexibility to adjust, I think, is very important. So I would say the standard risk, low burden of disease, no high risk feature, patient who has good support could probably stay on the triplet, and always having the option to deepen if they are not responding to the triplet. We can always adjust that way. And those who start on the quad, usually within 4 to 6 months, are on a triplet or just on a 2-drug maintenance, because these drugs really do get a deep response very quickly.
Well, I wish to thank you very much for sharing your thoughts on these two potentially practice-changing studies. And I hope that I can have you back for more in the future.
Thank you so much. A pleasure to be with you today.
Thank you.